Hello, everyone. It's Dr. Lisa L. Campbell. Welcome back to our weekly lecture for Introduction to CPT and HCPCS coding. Today is the day of the Super Bowl, and I'm excited about the Super Bowl. Love football. And we have a bit of a situation here in that this week, we have 5 chapters. So, one of the things I would recommend that you do is pace yourself because there's a lot of concepts that you're going to be introduced to, and it may be a little overwhelming, but you have to take your time. Additionally, as we enter into the surgery section, one of the things that I recommend that you do is Google on YouTube a video called CPT highlighting and bubbling. And one of the reasons that I think you need to look at this video is the creator teaches you how you can bubble and highlight your CPT manual to make it easier for you to digest, follow the surgery section. I don't know if I would bubble all the sections, but the surgery section, absolutely, because there's so much going on. All right, well, let's get started. This is part one of five, and by the time 5:30 p.m. Central Time hits, we will be done because I'll be watching the game. All right, so we have a lot of objectives this week. So, number one, being able to define the key terms related to coding procedures in the integumentary system. That's the first area of the surgery section. You also are going to be able to explain the organization of the surgery section, what is included in a surgical package, and coincidentally, in the week 4 lecture for the outpatient billing and reimbursement course, you actually are getting a preview of the surgery section or surgery section surgical package guidelines, but also Medicare's global surgical package. You also should be able to identify what are known as bundled services. Also, the purpose of the National Correct Coding Initiative, NCCI. This is a concept NCCI in particular, that you need to know for your CCS and your CCSP exams. So, again, now is the time to really lean into the material. All right, of course, there are anatomy and functions of the integumentary system that you need to be aware of, as well as abbreviations. Now, one of the things that I like about this book, nothing is perfect, right? So, there are things I like, there are things I don't like. So I love the fact that this particular book reviews the anatomy and procedures because let's just face it, you took medical terminology and anatomy and disease process to enter this program, right? But do you remember all of that? Probably not. So, also be able to define common procedures, the different types of graft, also assign the codes. That's the name of the game, right? As well as, when applicable, modifiers for surgical procedures, and then identify and code procedures from surgery and integumentary system from case studies. So, now here's the thing I don't like about the book: the case studies are not that detailed. However, I think that for an introduction to CPT coding, it meets our requirements. And let's just face it, right after this, you're going to be taking intermediate coding and you will see more realistic case studies. So I like the fact that this book allows you to grow. And my thing is all about growth. Now, the last thing that I will share with you that I think is very important, I mentioned the bubbling and the highlighting, but something else that I think would be beneficial to you is when you see a procedure documented, like the name of it, watch a YouTube video on the procedure so that you can understand visually what's happening, so that as you're seeing the paper, the words on the paper, it makes sense. One of the things that I am very grateful about in terms of my healthcare journey is that working as a medical assistant initially, I had a lot of time with physicians and surgeons. And so, for minor surgical procedures, I was able to assist the provider in the office. And that literally brought the words on the paper to life, right? And as you prepare for your career as a coding specialist, I don't want you to be a person who graduates, you pass your national exam, and then those records get in front of you real world and you're like, whoa, 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 right? So you have intermediate coding, you have your coding practicum over this summer. And so take the time to learn the industry that you're going into. All right. So the surgery section really is organized in a way to make code assignment easier because the surgery section is arranged by body system, right? And then once you get into that body system, what you're going to see is that the codes are then further subdivided by anatomical site. And the way that the anatomical sites are structured is that whatever body system that you're working in, it's going to start from the top and then go all the way down to the bottom of that body system. So it really makes it easier to digest. Now, once you get into the world of surgery, you're going to see two types of procedures: diagnostic versus therapeutic. Easiest way to remember them is diagnostic means we're trying to determine the diagnoses and then determine what's next, the plan. Therapeutic, therapy. We already know what the diagnosis is. The plan has been established. This therapy is executing the plan. CPT surgical package. So, where can you find the surgical package? It's in the guidelines. Remember, each and every section of category 1 of CPT has included in the front of it the introduction or the guidelines. Now, I'm not going to lie. The surgery section is the largest and the most complicated, so you got to take it a little bit at a time. In the introduction to the surgery section, the concept of a surgical package is presented. And so the surgical package, I always think of it like a value meal, right? Because basically, for one CPT code, you get all those things that are represented by a bullet in the guidelines, and there are 6 of them. All of those are included in that one CPT code. So, you know how you get a value meal at a fast food restaurant and you get the fries, the sandwich, and the drink? It's a package. It's like a value meal at McDonald's. Same concept here. One CPT code for all of these services, and basically these services are considered to be integral, included, and you can't bill them separately. Um, I did want to just call out that, and I mentioned this a little while ago, but I just want to say it again. Medicare has a concept called Medicare Global Surgical Package, and that's actually discussed in your textbook. And so you'll want to make sure that you take a look at that. All right, NCCI. We actually talked about NCCI before, right? National Correct Coding Initiative. And what the NCCI is all about is decreasing improper payments. And initially, NCCI edits were created for when you're coding for the provider, the physician, nurse practitioner, physician assistant. But as the years evolved, Medicare was like, so when Medicare pays for the services provided by the physician, the provider, that's paid under Medicare Part B, right? And so Medicare was like, whoa, this system is really working well. So we're going to expand it where there is NCCI edits for outpatient hospital services as well. And I bring this up because I mentioned that for both exams, you need to understand NCCI. And that's why. It's because it applies to both. Okay. So what this is, and we talked about this in the insurance class. The NCCI, you can actually find them. Hopefully, I say hopefully because the governmental websites have changed over the last 30 days. But on the CMS NCCI website, you can actually download the edits, which are basically uh, Excel tables, Excel spreadsheets, right? And on them, there is a column one and a column two. And these are known as comprehensive component edits. And then the second table that you'll find are the mutually exclusive edits. And the codes that are, and I'm trying to give you this visual, but it's also in the textbook. The codes that are listed in column two of the mutually exclusive edit tables are not payable when they are present on the claim with column one. So it's almost like column one. I'm thinking about Pac Man, if you're old enough to know who that is. Column one essentially um, eats up what's in column two. Now, there are situations where the code in column one and column two can be reported together, but that basically means that there's a modifier that would need to be applied. What else did I want to tell you about NCCI while I'm thinking? So here's an example of that two column format. You see column one, you see column two. So basically, what this is saying is that the services in column two are bundled into column one. Bundled, they're not separately payable. And then mutually exclusive are services that cannot physically be performed together during one encounter on the same anatomical site. And so in the on the edits, you'll see what are known as mutually exclusive code pairs. Um, in some instances, they can be reported together, but as I mentioned, a modifier is required. So those pairs, by definition, would not be done at the same time. So now let's transition into two terms that you'll need to know, which are unbundling and fragmenting. I did want to call out in the textbook, um, you are actually given a link to the NCCI table. Let me see if I could do something fancy. And I'm always doing something fancy. That's just what I do. I'm going to add, scrolling down at the bottom of the screen, the website. Now, Don't quote me on this website. This is what's in the book. And you know what? I just clicked on that page, and guess what it said? Page not found. Well, let me see if I can actually find it. So one thing I will tell you, and I did find it, and I'm actually glad that I did this because you might have been looking for it and have been like, "Whoa, where are those edits?" So one thing about government websites, they can be changed. And we are seeing a lot of changes with government websites due to the new administration that's in the White House. And so, under President Trump. And so, I would just recommend that you know, locate the site today, save it into your files, but know that it could change. But all you have to do is the website is cms.gov, and it's the Medicare National Correct Coding Initiative NCCI edits. All right, so back to unbundling and fragmenting. Okay, so unbundling is when you try to build, I said you, right? You try to build two procedure codes, but only one would be applicable, right? Fragmenting is several procedures performed at one surgical encounter, rather than using one code to capture the service. So you kind of like fragment, and fragment is actually it's actually an English word. um I'm gonna just see if I could find another definition that would make sense. So fragmenting is actually a type of unbundling. Okay. One thing you'll know about this industry, none of us can know it all, and you forget things. All right, because none of us are perfect. All right, denials. So if you continue to unbundle and fragment codes, that's a red flag for the insurance company. And insurance companies are actually um, looking at your coding billing habits, which could then trigger an audit to determine whether you're doing it on purpose or not. And if it's determined that it was intentional, there are fines that will need to be paid to the payer. All right, so now enough about NCCI, because this is not the billing class. Luckily, we have more on NCCI in the billing class. So, in your textbook, you will find some abbreviations related to the integumentary system. And I like that because sometimes physicians do use abbreviations. And if you don't know what they mean, you got to stop and look them up. So, the integumentary system, as you may recall from your anatomy class and even your medical terminology class, it's the largest body system. It is the largest body system because it is a shield for our entire body. And the integumentary system has many functions, which include protection of deeper tissues by retaining fluid in the body, regulating our body temperature, and really controlling the amount of heat loss. Now, this is not an anatomy class, so you can read more about that. And here are the abbreviations that I was talking about. And one of the things that I like to say, I'm actually in the middle of doing a CCS exam prep course. And one of the things that I told the participants in that course is that they're going to be over prepared for the exam, instead of under prepared, because you never know um, you never know what you never know what your future is going to include. All right. So, as you know from anatomy, the skin has three layers: the epidermis, the dermis, and the subcutaneous layer. The textbook actually gives you a visual of that. And when we are coding procedures performed on the integumentary system, one of the things that you will see in the actual manual is that the codes, many of them, rely on measurement of the area in the documentation so that we can assign the appropriate code. So I know in the introduction to diagnoses and PCS in the guidelines, you heard about the word query. So, if you need to code something that requires centimeters, which is what is required, and it's not documented, you will have to query the provider to get that information. You must have the information in writing. It cannot be something that is verbally said to you, it must be in writing. All right. So, procedures that you're going to see: aspiration, that means where they are surgically removing um, fluid from the body. And in the first part of the integumentary system, you're going to see fine needle aspiration codes under an area that is titled as general. So I said the integumentary system is first, but these general codes actually come first. All right. So what you see is an FNA, or a fine needle aspiration. And as the name implies, a very fine needle is inserted into that site. They take out the fluid. And for these procedures, the provider may use some type of imaging guidance. Imaging meaning CT, ultrasound. And so when you look at these codes, what you will notice is that they are organized based on with and without guidance. And then if it's the initial one and the the subsequent one. Okay. There are some notes, subsection notes. This is your first introduction, or then maybe not, because you had anesthesia and you had evaluation and management, but this is your introduction to some detailed subsection notes. And this is, in your CPT manual, when I talk about bubbling and highlighting, you'll see why you need to read the stuff first, because on the day of the test, you're not going to have time. You're just not going to have time, literally, to read this on the day of your test. You got to walk in the door knowing it. So those codes are organized based on um, if guidance was performed. And so you'll want to take a look at that. And since your lectures are recorded, something that I would recommend that you do, this might take you a little longer time. And of note, I did extend the due date for your discussions for this week for this course, because you have so many, to Thursday instead of Wednesday. But I would encourage you to have the CPT book in front of you as I'm walking you through these areas so that you can see it real time. Okay. Next up, we have incision and drainage. There's also an area called introduction and removal. But what you're going to see here is services for surgically cutting over the area to be drained and then withdrawing it, getting out fluid, or actually draining it. And the codes are organized based on the type of abscess or cyst, as well as whether or not the incision and drainage was simple or complicated. Next up, we have debridement. Oh, something else I want to tell you as you're looking at these numbers, and it's something to consider when it comes time to code, is that a lot of these codes are out of numerical sequence. And so you're going to see that symbol that tells you that it's out of order. All right, so debridement is a cleansing, right? And it involves removal of dirt or foreign body along tissue that is dead or damaged. So dead meaning necrotic. And this dead tissue is damaged in a way that hinders the patient's ability to heal. Okay. So in the CPT manual, you're going to see services for injuries, infections, wounds, chronic ulcers. And so, in order to properly code the service, you need to know the depth of the tissue removed and the surface area of the wound. Now, there are some codes that require the percentage of the body surface be captured, but you'll actually see that when you get to that area, which is why I am saying, it might be worth your while now to look at those areas. For planning purposes for this lecture, I'm about halfway through. This is probably going to be the longest of the five. And so just wanted to give you that heads up in case you want to pause and go to the bathroom, go and get yourself some water or something like that. Okay, biopsy codes. So, biopsy codes are when we are sampling tissue removed so that the pathologist can examine it. And these particular codes are used for the skin, subcutaneous tissue, um, also mucous membrane. It should be noted that you cannot assign a biopsy if a more involved procedure is performed at the same time. So there's actually a note in the manual that speaks to the fact that if they take out the appendix, for example, and they send it to off for a biopsy, that biopsy is not separately reported. Anytime they take out an organ, they generally send it to the lab for analysis, just to make sure like it's not cancerous. All right, skin tags. So, skin tags, there are only two codes available here. These are growths that are found on many areas of the body. If you've seen one on someone's body, face, you can recognize it. These are usually removed with scissors, scalpel, or ligature strangulation. And if you have your manual open right now, what you will notice is that these codes are organized based on the number of skin tags that are removed. Something I will just call out is that in the second code that you see for the skin tags, it says each additional 10 lesions or part thereof. So, what does that mean? So, first off, that first code is for the first 15. The second code is for each additional 10 or part thereof, which means you could have eight. You can have 15 plus eight, and you can still use that add on code. Why? Each additional 10 lesions or part of 10, but it has to be more than 15. So now let's say you have 30 skin tags. You definitely will have the 11200, that's 15, and a 11201, that's 10. 15 plus 10 is 25. You had 30, you need another code to get that 30, each additional 10 or part thereof. As a reminder, anytime you see an add-on code, add-on codes cannot be used alone. All right, next up, we have removal of a lesion from the epidermal or dermal lesion without incision. This is known as a shaving procedure. This is a horizontal movement. The codes are divided based upon the anatomical site and the size of the lesion. And of course, it's going to be reported in centimeters. All right, lesion excisions. So, lesion excisions in our CPT manual are represented by two families of codes. Those codes are either benign or they are malignant. And with these codes, one of the things that you will notice is that within the codes themselves, they are organized based upon the site that the lesion is being excised from, as well as the size in centimeters. Okay. So when you're coding excision of lesions, you have to make sure that you review the documentation to get that size, to get that anatomic site, and as well as if it's benign or malignant. Okay. Um, Also, notice the range of codes for malignant versus benign. And I say this because they look very similar. And so, something you want to just take note of. All right, routine foot care. This is something that you see um, um, commonly discussed because Medicare does not cover routine foot care. And so, in order for our purposes, we have to understand what their definition of routine foot care is, because with certain conditions, they will cover the routine foot care. And I'm looking at the slides. I really feel like those codes are incorrect. Um, I do not create these slides. I just deliver the material. But I happen to know some of the numbers. So let me just, I don't have a pause button on this system. So um, yeah, so let me just um, put a little message up that shows you the correct codes, because those um, are definitely not correct. I apologize for that. All right, so here are those are the correct codes for um, pairing or cutting of hyperkeratotic lesions. Okay. And so Medicare has this whole thing about what is considered routine foot care, but they will only pay for it if the patient has conditions like diabetes, peripheral vascular disease, metabolic or neurologic diseases, and you know, like anything else, they're going to require some medical necessity. And now I'm sitting here thinking, what's 117 11719 to 11721? I have my CPT book near me. So that's for actually for trimming and cutting of nails, which Medicare does not pay for. I don't think they pay for trimming or cutting of nails. Um, how would you know? Um, there is, so actually they do. There is a um, local coverage determination that is published by Medicare that actually tells you what is considered to be routine foot care and what is needed to qualify for reimbursement for those services. Okay, that just messed me all up. All right, you'll you'll correct that in the book because the slides threw me off. I'm sure they probably threw you off well, but the bottom line is Medicare will pay for routine foot care with some exceptions. Something else I did not mention, let me just call this out real quick, is that Medicare will pay for these services, and um, they are looking for what are known as class findings, class meaning A, B, and C. And the class findings reflect the clinical findings of patients with severe peripheral involvement. And what happens is when you're reporting these codes, Medicare is looking for modifiers that reflect the class finding. These modifiers start with the letter Q. And again, a class could be A, B, or C. So it's a Q, 7, 8, and 9. And because it starts with a letter, you probably guessed those are indeed HCPCS modifiers. All right. Procedures on the nails. Those procedures um, are for these procedures here are for avulsion of a nail plate as well as excision of a nail and nail matrix. Now, that's not all that's over there because there are biopsy of nail codes, evacuation of a hematoma underneath the nail. You have debridement of the nail. So when you are over there reading those codes, you'll see them. All right, repair. So, repair, also known as a laceration repair, is the surgical repair or closure of a site. There are three complexities of repairs. First, we have simple, which is a single layer closure. Then we have intermediate, which is a layered. So notice simple is a single layer with a ER on the end. Let me go back. Layer closure. Simple single layer closure. Layered is what you find in intermediate repair, and this is where the laceration does not go deeper than the muscle fascia. Then you have complex. Complex involves reconstruction, skin grafting, stents, sutures, as well as some extensive debridement. And so, as it relates to the wounds, there is a percentage that is used to identify if the wound is clean, very low infection rate, 1 to 5%, or clean contaminated, low infection rate. So the first one was very low. This is low, 8 to 11%. And then it gets really higher where it's contaminated or dirty. All right, try to wrap this up in the next 12 minutes. All right, adjacent tissue transfer or rearrangement, and this just happens to be a long section. So, adjacent tissue transfer is where healthy tissue is manipulated or rearranged from the site close to or next to an open area. So, adjacent means near, and they're transferring that healthy tissue over to the area that has a disease or injury. Then you have a pedicle flap. This is a flap of skin that hangs onto a stem of the skin that contains a blood vessel. So you'll see a pedicle flap transfer as well. And in the CPT manual, you'll see codes for that. With these services, you will see that the first two codes are identified as some type of surgical preparation. And there is a note in the manual about surgical preparation. And they identify some terms you'll need to be familiar with: the recipient site, the defect, and then the donor site. So the defect, the recipient site, they're receiving something, right? That's the area that's going to receive the graft. The donor site is where it comes from. So you'll want to check if repair of the donor site is included in the code selection. And the CPT manual has a subsection note that says with these adjacent tissue transfers or rearrangement, lesion excision is not reported separately if it's performed at the same site. So when I say now is the time to read these things, this is what I mean. All right, next up we have grafts. And this is where a section of the tissue is moved from one site to another site in order to heal the site or repair where that defect is. CPT manual calls out many types of grafts: autogenous, homogeneous, homologous. And what you need to really just understand about the differences of these is where it's coming from, right? Auto means self, right? Um, Also, you'll see terms like free, split thickness, split skin. Those are just the different types of grafts. So, in order to code that graft properly, you need to know a few things: the size of the defect, the location, the type of graft, the actual documentation, and any other pertinent information to that patient's care. We also have flap grafts, skin cell suspension, autograft. Auto means self. This is where the patient could potentially donate their own skin for this. There are several types of this type of procedure. You see them pedicle tube, delayed, and direct. You will need to determine if the graft was reported by provided by the recipient or the donor site. Pressure ulcers, also known as bed sores. These are erosions of the skin. The tissue becomes inflamed and then lost. You see this quite frequently in patients who are bedridden, and um, they sit in that one spot for a very long time. And as a result, that tissue area becomes inflamed. So, with these particular codes, they are organized based on like the site, as well as when the provider does the repair, if they have to actually um, remove bone. And so the word that you will see in the documentation is an osteectomy. And you know that word from medical terminology. We're almost done. Burns, local treatment of burns. So, a burn is something that happens when there's heat, flame, sun, chemicals, radiation, and electricity to the body. And these codes here, I use the word local because these codes only encompass local treatment of the birth of the burn surface. If the patient needs further related medical treatment, there are additional codes that can be reported. With these codes, the textbook talks about the degree of the burn, and they call out the rule of nines. But actually, I seem like it's been like 10 years ago. The CPT manual changed to the Lund Browder. And let me see if I can find that word for you. Um, just because I want to make sure. I know you're going to see it in your book, but the Lund Browder is another system that is used to classify burns. So I'm going to just type it here just so you can see it. All right, there we go. And so the Lund Browder system, Lund Browder system, also uses percentages to capture burns. It's done a little differently than the rule of nines. All right, let me remove that. I promise we're almost done with part one. All right. Next up, we have destruction codes. And one of the things you want to pay very close attention to when it relates to the destruction codes is that you will need to determine from the documentation if the lesion that is being destroyed is benign, pre-malignant, or malignant. That will help you in determining which code to assign. The other thing that you'll want to note about these codes is that they do identify like the first lesion, each additional lesions. And so you want to just be clear on what quantity was removed and that your code assignment reflects that, right? So, for example, 17000 is for destruction of pre malignant lesion. And this code is used for the first lesion. The code that's right underneath it, the indented code, is an add-on code that is reporting the second through 14 lesions each. Oh, something I want to call out here. There is no part thereof in that code description. So one of the things that I want you to remember, don't carry over descriptions of codes from one code family to the next because they could vary. In this particular case, if you have more than 15 lesions, we have a code 17004 that's also in that family. And that's where um, highlighting and bubbling will come into play. All right, Mohs micrographic surgery. This is a type of chemosurgery, and this is where they use a chemical agent, which is like a fixative, that's placed onto the lesion before they take it out. And the fixative allows the surgeon to determine the extent of the tumor and the margins around it. And so once the tumor is excised, the surgeon is actually also acting as a pathologist as more tissue samples are divided and more examination is done. They basically are examining to the point that they get down to that healthy tissue. All right, so these codes are not applicable if the physician doesn't do both. So they have to be the surgeon and the pathologist. I was driving by the mall one day and I saw a Mohs micrographic surgery place. And when I tell you, I got so excited. My husband was like, "Oh, you and that coding, you just get excited over all this type of stuff." I'm like, "Well, yeah." Okay. So, you want to pay close attention because some of the codes are add-on codes and they are organized based on um the block that is removed. You'll see that when you look at the codes. All right, we're coming to the end. Procedures on the breast. So the procedures that are on the breast are organized into incision, so otomy, excision, ectomy. If they are introducing things like breast markers, you also are going to see mastectomy codes. You also are going to see codes for repair and reconstruction. So you want to read your documentation to determine what actually happened with that patient and assign the appropriate code. Now, I don't know why this slide is all the way here. Something must have happened with that. But here are those modifiers that I was talking about earlier related to the class findings, the A, B, and C, the Q7, Q8, and the Q9. All right, so long chapter, but we looked at all this stuff. Terms, organization, surgical package, bundled, NCCI. You saw those abbreviations, some basic anatomy. You'll see more in the textbook. You saw some common procedures performed. We talked about grafts. We talked about a few modifiers. And at the end of the chapter, there are some chapter review questions as well as some case studies. And I would highly recommend that you practice with those. They're generally like 10 case studies because you don't want to get to the end of this class and then go to your intermediate coding class and you can't code case studies. That's going to be a problem. I'll see you in part 2.